one, again, I don't know how the other prices are arrived at. I know if the result is a 2% margin and our prices are higher and his margin is higher than ours, then he has lower prices than from what you are saying that those costs are higher. I think there are a variety of issues. One is that, as each of us has described, we have a pretty broad-based mission. That mission includes pretty extensive investment in our communities that our hospitals have lived in for long periods of time. I think we all invest in those communities, and we essentially budget for making substantial investments, including the 6 community health centers that we own, five or six, excuse me, as well as those that we're affiliated with, the capital expenditures we make there, as well as an investment in training and science, which are each critical elements of what our mission is. We have essentially in budgeting, in so doing, focused on the investment in safety, basically over the course of the last decade, on the efficiency and safety side, since really the crossing the quality chasm became the watchword for healthcare redelivery. We've invested in information systems in a way in which we essentially required our entire network to adapt to them before those requirements existed before, focused on error reduction with computerized physician order entry and electronic medication administration record, and engaged with payers in discussion around and incentives around the implementation of those safety mechanisms, as well as reductions and creation of efficiency in those processes. Those have created some of the basis for our cost and the investments that will relate to them as well.
What about labor? We've heard some stories here about community providers that are losing staff and physicians because they don't pay as well as somebody else. I was with a primary care practice a couple of weeks ago, and they said they lost a primary care physician who went to a Boston teaching hospital, not yours, but went to a Boston teaching hospital because the physician was going to get a salary 30% higher. Is higher labor costs, and I assume a lot of your costs are labor, given
that's 70% of our cost of labor, right?
Is that part of this?
Labor cost, I don't know that our labor costs are higher or lower relative to each of the individual hospitals relative to our prices. I can't speak to that directly. I know when I look at salaries for unionized employees when we go to negotiations, that they're at the higher end in those categories. Our physician, I don't believe, essentially our objective around our negotiations started years ago when there were substantial discussions here in and around this marketplace about the loss of physicians to other markets, and our competitors, like others here, are not just here in Massachusetts, they're throughout the country, was to get our physicians to rates in terms of their salaries that were comparable so that they wouldn't leave Massachusetts. On the other hand, I can't tell you that our salaries for primary care doctors are significantly greater than others. I don't know what those are, but that hasn't been a major focus.
Mm-hmm. All right, but I'm picking up that there's a little push and pull that the community providers are losing staff to those who can afford to pay them more, and your competitive concern is you're losing your staff to perhaps providers in other states that can pay them.
Yeah, I think that's what kind of set the benchmark for where we started to move our negotiations. Really, back more than a decade ago, right after the balanced budget amendment, when we heard really from the Secretary of Health and Human Services, who said that in our marketplace, our payments for private payers were in fact disparately low relative to other marketplaces, and we were over-dependent on the Medicare system.
All right, so